Welcome to the Pathology Report. I'm your host, Kym Mina, and I'm joined by Louise Lyons this afternoon to talk about Indigenous genomics. Louise, I thought before we got started, it'd be nice for you to perhaps share with us a little bit about yourself and the work that you're doing at the moment.
Tokmuil, Naranek Luich, Kapkap Jurek Malintanich, Bajukua Lairuk Jaadwa. So, just introduce myself in the Wagai language of Western Victoria, where I'm from, and I'm a proud Jaadwa woman from Western Victoria. I'm also the Senior Manager of Strategy and Policy for Indigenous Genomics at the Kids Research Institute Australia, and I've been there for about 2 years now, working with Professor Alex Brown in Indigenous Genomics.
Louise, what is Indigenous genomic governance and why is it an important component of genetic research?
Well, taking a step back, Indigenous governance in research or in service delivery, health service delivery, is really recognising Aboriginal ways of knowing, being and doing, and really understanding what's needed to address inequity of access to health services and research. And so, like a lot of underserviced populations, it's great to know what's needed and how to address, so understanding the barriers and then looking at ways to address those barriers to ensure that patients or research participants have access to the services that you might be providing. Now, in genomics, it's no different. It does add a layer of complexity because the language is often not understood. If people need to go and have a genetic or genomic test, they're often entering into an environment and hearing language that they've not heard of before. There are issues around cultural safety, feeling safe within those environments. I think that's largely due to the fact that as Aboriginal and Torres Islander peoples, we've had some historical issues with stepping into public hospitals, for example. It's where our children were taken many years ago. And so rebuilding that trust, rebuilding that the cultural safety of those services, ensuring staff understand the history so they understand what some of those barriers are and how they can put people at ease, I think are really important. So that goes to the heart of Indigenous governance. And then there are, I guess, the more structured ways in which you can build governance within environments, be it a laboratory, a hospital, and looking at how you can address those needs of those people in a way that they can engage safely in your service. Because really what we're trying to do is ensure everybody gets access to the services that they need.
What are the key considerations when translating research knowledge into culturally appropriate practices and models of care to promote health?
I think it's important to, first of all, recognise or understand or find out whether or not the information has come from the populations or the peoples that you're trying to service. So, for example, engaging in understanding what communities, what Aboriginal people, Aboriginal and Torres Islander people in communities might need or want, or what they prioritise as being, for them, the main health issue that they might be facing or health issues. What we see as researchers and policy makers is that a lot of the research that's conducted in Australia is conducted without consulting the people on whom the research is going to be held. So really understanding what a community wants and needs or what an individual needs, exploring whether there is an opportunity to co-design research, or whether there is an opportunity to engage, for example, with someone in that community or in the health service to step into a research role to help participants on their journey, those sorts of things. I think in a health system or a health environment, clinical environment, it's not dissimilar. So understanding the patients that walk through the door, who are they? The other issue, I think, is understanding who your Indigenous patients are. Are you collecting that information? Do you know when people walk in that they are Aboriginal and or Torres Strait Islander? I mean, I may not look typically Aboriginal, and I do get asked, are you sure?
Oh dear.
I have been asked in a public hospital when I've said I'm an Aboriginal patient. They said, oh, are you sure? So I think, learning how to ask those questions appropriately, learning how to put people at ease, ensuring that they can step into the environment safely is really important. So if you've done your due diligence and you've engaged and co-designed and implemented work together with Aboriginal people, then that is translating those models into practice. I think ensuring that your staff are highly trained, particularly around cultural issues. I'll only speak for Indigenous populations, but this could also be for many underserviced populations in Australia. We're a multicultural society, and I think everybody deserves the same rights in being understood. Having information in a language that people understand, and I don't mean that by necessarily translating from English, but really making sure that the language in English is understandable. I mean, genetics and genomics is a whole different language in itself.
Even for English speakers, it's challenging, so I can imagine then translating it to another language even more complex.
It is very complex. So, what we're working on is developing a suite of genetic and genomic health resources with one of our key partners, the National Centre for Indigenous Genomics. Professor Alex Brown also heads up that centre as director in his appointment at ANU. And Associate Professor Azure Hermes, amazing Aboriginal woman, is leading all of that work. But what Azure and her team have done is brought together Indigenous representatives from a range of different jurisdictions, from way up north in near Cairns, Yarrabah, up that way, Galawinku, there on Elka Island. Here in Victoria, we've got representatives from VATCHO, the peak body here, and others. And so we've come together to talk about and develop genetic and genomic resources that can be used by communities, by Aboriginal health services and mainstream health services to better understand what the needs of Aboriginal people are, but to explain what genetics and genomics are to Indigenous Australians. So they understand when they step into those environments what it means to sign for a genetic test. I mean, it's the only test you've actually got to consent for.
Yeah.
So what does it mean? Do you understand it? Is that informed consent once you sign? Do you know that you can say no to, for instance, reanalysis of your sample, for example? So there's just a lot of information we're getting out there, even talking about DNA. What is it? What does it mean?
Yes, indeed.
But and also contextualising that information so that Aboriginal families understand what it means, because Aboriginal families are often constructed differently. It may not be necessarily, you might have different sets of parents. And so if you talk about a test, you've got to talk about it being how biological, like it means when we say it comes from your mother and father, we mean your biological mother and father,
right?
Those traits or that test relates to. Whereas in many communities, you might have different sets of relationships, parental sets of relationships that aren't not, those people may or may not be necessarily related to you.
Does family have the same meaning, or?
I think it's probably different for everyone.
Yeah, well, that's fair.
But I think it's more nuanced around the kinship relationships that have been developed over thousands of years with Aboriginal people. And if you think about how those kinship relationships were developed, I think there were two main reasons that I'm aware of. One is that no one is left alone. So as a child, for example, if something happened to your parents, there would be other sets of parents or people who would take responsibility for you no matter what. Sure. You were never left alone. Yeah. No one was. And equally, Aboriginal people learnt very early on, I'd say for thousands of years, have practiced moiety systems where who you can marry is very important and who you can have children with is very important in order to have healthy children. So the practice of genetics was happening for thousands of years before Western science caught up and realised it probably wasn't a good idea to marry your first cousin. So I think, we have a lot that we can bring to genetics and genomics. I think we have a lot of history and knowledge that can come into this space. And I think there are a lot of people willing to share that with, clinicians and researchers in the mainstream that could probably broaden their ideas around research and clinical practice by engaging with Indigenous peoples.
Indigenous data sovereignty is essential. How do we maintain and respect that and use genomic data for medical care? Is there a clear answer to that?
Well, I could probably answer this a couple of ways. Sure. I think the first is how can we use it to benefit medical care of people? Goes back to informed consent, making sure people understand what they're having tested, what the results of that test might mean for them and their families, why is it important, what could happen if a certain result comes up that they may or may not have expected. All of those really complex things that come up with genetic tests are important. That knowledge informs people and people make decisions around what they know. So that's important. That's the first thing. In terms of describing Indigenous data or biospecimen sovereignty, I'm going to paraphrase a researcher who I admire greatly, an Indigenous researcher, Associate Professor Kalinda Griffiths, who works up at Flinders University. She's head of the Posh Research Centre in the Northern Territory and South Australia. And she, I believe, clearly defines the fact that sovereignty is never given away, it's yours. So it's not so much yes, it is the sovereignty of that specimen or that data, but more importantly, it's the governance of that data or that specimen. What happens once it leaves your body? What happens once the laboratory takes hold of your blood, generates data, results? Third parties could then be testing it as well for different reasons. It could be open up for research and so on and so on and so on and so forth. That is the governance of your specimen or your data. That journey is really important, and the processes and the protocols that are agreed to at the beginning for what happens is what we're talking about. And I don't think this is just an Indigenous issue. I think that we talked before, I think when we address these issues and perhaps raise the bar around the quality and respecting the wishes of the people who are giving their specimens and their data for either a clinical reason or for research, for science, advancing science, then we lift the bar. So as soon as we start to address these issues with one group and we resolve some of those issues that exist, we raise the bar for everybody. And I think that's really important because I think it is not just an Indigenous issue.
I think you touch on an important point there because there's still, I think, a lack of clarity as to, we talk about data, who it belongs to, versus a DNA sample that's come from a patient. So I can see actually that by exploring this from your perspective, you will raise the bar for everybody and we'll get a better understanding.
Yeah, and it might mean, I know for some communities, it might be important for them to have their samples repatriated back to community because, their blood or their specimen is part of them. It's who they are. It might mean that we need to explore models of cultural support for those specimens as they take their journey through to a research environment. Do we provide a cultural custodian or is there a cultural custodianship model that can support those specimens as they take on their journey? I don't think, I have heard it said before that these sorts of processes or this type of thinking is holding back research. It's not. It's about getting it right. It's about getting the fundamentals right on a, humanity level. And I think once we do that, of course, things will, progress and research will be conducted and we'll certainly get a lot more knowledge than what we have today about how to treat disease or prevent disease. But we've got to get it right because, unfortunately, in Australia, we've had a very poor history of research being conducted on Aboriginal and Torres Strait people with very little benefit unless there is leadership, governance, priority setting, understanding, communication, all the things that you would expect in research, unless that's embedded within that research with Aboriginal and Torres Strait peoples, and you're going to get a poorer outcome. So I think it's really important that we have these conversations and so that we can keep advancing, let's say, these ethical or moral issues that we're trying to embed, but for us they're cultural issues as well. And as I said, what we do for Indigenous peoples, we can look at how we can apply similar models for other groups as well. Sure.
Yeah, okay. How are Indigenous priorities in genomics determined?
Good question. Very good question. Like most of our work in this space, when I'm talking about, for me, particularly Aboriginal health, been in Aboriginal health for quite a number of years now, it begins and ends with building trusting relationships with communities or groups of people that you do want to work with, and really understanding what they want, what's important to them. It may not be a health issue. You might be a health researcher and you may have analysed some AIHW data and thought, gee, there's some research in here that I think is needed and I think will benefit Aboriginal people. Let's just start doing it. And, in consulting with Aboriginal community members, might find that that's not their highest priority. There might be something else that's going on there that they would like to see researched, that they would like to take part in, that they would like to co-lead with, that they would like to co-design research around, that they would like to continue to work with that group ongoing if that research delivers a benefit back to the community. So that cycle of building trusting relationships, engaging early and often, ensuring that whatever is found in that research, and not all research delivers a benefit, but whatever you do, come back and talk about it and explain what you have found and explain, why you did or didn't get the outcomes that you promised up front. That's really important. Most people will say, fair enough, at least you're telling me, I know what's happening. Yes. It's the not knowing that's incredibly difficult. And there are still researchers and research today that do not come back into communities and explain what happened to that research, what were the outcomes. It is an expensive part of the research, the pre-planning, and the coming back often was not funded in some of our research, and we can spend a whole other podcast talking about the lack of funding in research generally. Yeah. But I think if you are serious about this and you really do want to make a difference and you really do want to build those relationships and partnerships with Indigenous peoples and communities, take the time to do it properly, engage with your local Aboriginal community-controlled health organisations or peak bodies in your jurisdiction, build the relationships with those groups first and build that partnership that then enables you to walk into these organisations and into the communities with more knowledge and an understanding of what's needed. And I think the research will benefit straight away. So in genomics, what are we doing? Okay, so similarly, same model, we're talking to communities. Now, Azure Hermes, who I mentioned earlier, has done a huge amount of engagement with various communities around Australia. We have researchers in part of our group in Queensland doing the same, Indigenous researchers. Professor Alex Brown undertakes a lot of community engagement consultations and his teams. So we literally don't stop. Our whole aim is to understand how we do this better. We've set up Indigenous governance, a very strong Indigenous governance structure under the Australian Alliance for Indigenous Genomics, one of our MRFF funded programs. And 6 of our 8 jurisdictions in Australia have one of these Indigenous governance committees set up under a line where members come from local communities, from local health services, and they inform the discussion. They provide advice, they give us feedback on our research, they ask good questions, and use their knowledge systems and their expertise to guide our research in a direction that it should be going. We also have a national council that has 4 standing members, plus 2 members from each of those 6 Indigenous governance committees. And we meet 3 or 4 times a year and present and talk about a lot of the research we're doing and get their feedback. So the genetic and genomic health resources that I mentioned earlier that are being developed will go through these Indigenous governance reviews and we'll make the changes that need to be made. The Indigenous governance members come up with some fantastic ideas of what we should be doing.
Okay.
Sometimes we can, sometimes we can't. Sometimes we say, well, hang on, hold that thought. We'll have to go and get another grant for that. But, I guess what I'm saying is, once you've got these Indigenous governance structures around you or you can access them, your world opens up enormously and you start to hear what people are saying they actually want and need and not assume what they should, what the research should be about. For hospitals, health services, pathology services, really have a look around and see who you can connect to. Your local ACHO, your local Aboriginal Health Service, your local hospital community advisory committee. Are there groups already established that you can go and speak to, present to, seek advice from, build partnerships with? That would be the suggestion I would take, and particularly in genetics and genomics where we're still struggling with the language and trying to get a head around what it all means.
Louise, do you think, it sounds like there's been lots of progress from what you're describing. How far have things actually come?
For us, we've only really been around for 3 years. Professor Brown is a medical doctor and a public health doctor who has credible clinical and research experience in diabetes, cardiovascular disease, in Indigenous communities. He's worked mostly all his life in Indigenous health. And a few years ago, he realised there really wasn't much being done for Indigenous genomics, and he took a big step in and surrounded himself with a lot of really good people, really good staff, those that can guide and advise him and the team on the direction that we need to take. So in 3 years, I think we've achieved a lot. It's just the beginning. We need to do a lot more. We are really struggling at the moment to address some of the inequities that exist in accessing genetic and genomic services and research, and working with groups like the ANZCTR, the Australian New Zealand Clinical Trials Registry, Australian Commission for Safety and Quality in Healthcare, working on the National One-Stop Shop for Clinical Trials, work that's being undertaken. We've met with NACHO, the peak body. We have a great relationship with NACHO, peak body for Aboriginal health services in Australia, and through them have now connected with Big Pharma here in Australia. Part of that relationship is to explore equity of access to clinical trials, ensuring that Aboriginal people are represented in clinical trials. Now, the fact that we don't have any way of knowing how many Aboriginal people are in clinical trials is the first big problem. So building a system that can collect that data is important. So asking whether a participant is Aboriginal and or Torres Strait Islander and recording it is an important part of this system that we're building. And the other area that Big Pharma are really helping us with, and we're incredibly thankful and grateful, is looking at how research protocols can be developed to include underserviced populations, including Indigenous Australians. A lot of these research protocols, as you know, are developed overseas, Europe or in the US, and they tend to screen out people with complex health conditions or risk factors like smoking, for example. So we said, look, here's the challenge. What do you think? Do you think we can look at including more Aboriginal and Torres Strait Islander people in your trials, and how could we do that? So there's been a lot of work done to address this or redress this, including collection of identity on case report forms in clinical trials. So, yeah, we're getting there.
I feel like this is a big question with a big answer, but we'll give it a go.
Okay.
How do we achieve culturally informed engagement and governance strategies to support communities in their decision-making about genomics and their data?
Big question, but I think we've sort of covered most of the ways in which we could do that in this discussion. As I said, building a relationship, ensuring people understand what genetics and genomics means for them and their families, building the resources, building capacity and capability of Aboriginal health workers and other clinicians in our health services, building knowledge of the needs of Indigenous patients in the mainstream health services. There's a piece of work that NSIG about to undertake. They received an MRFF grant to explore working with genetic counsellors and community members to bridge that gap. What do genetic counsellors need to know about what community needs to know, and vice versa?
Right.
Because we talk different languages. And I think we've got to bridge that language gap and make sure that we're all on the same page when we talk about genetic and genomic testing. I think we need to demystify genetics a little bit and genomics. I think we need to separate the difference between genetics and eugenics. Bad word, I know, but unfortunately, and it's come up in our community consultations, particularly in Victoria and some of the southern states where colonisation was incredibly brutal and really poor research was being conducted. There was there were flourishing eugenics movements here in Victoria until the 1970s. And so you think about the context, that backdrop and the context of what people hear when they hear genetics. I think it's all about this white supremacy and, we're somehow inferior. Is that what you're saying? They're saying, no, that's not what it is about. So demystifying that, ensuring people are comfortable with the language and speaking in a way that people understand what this is about. And I think one of the biggest areas that I see we can do that is through precision medicine. I think there are such great advancements in precision medicine in this country. If you think about genetic typing of tumours and precision, oncology and, what that can bring to people in personalised medicine is amazing. But until we can get Aboriginal people into that space, they'll continue to miss out. So we're constantly looking for these opportunities to bridge the gap and to ensure everybody has access to these amazing discoveries, treatments, diagnostics, whatever's out there. We want everyone to be a part of it.
Okay. Louise, this has been so wonderful to listen to. Thank you so much for your time.